Hi everyone, welcome to week 4, module 4 in intrapartum. I'm hoping that you're all having a great time at your intensives. This is my first fall semester without a student with me for many years, so I feel kind of out of the loop as far as that goes, but I'm sure some of you have caught babies already. Some of you maybe haven't even gotten to your site yet, but I hope you're getting close to getting there, and if you're there, you're having a great time. I know as a preceptor myself for as long as the program's been going, I'm anxious too when I first get a student. But as soon as they're there and we've met, it seems like it goes so well. Keep in mind, every preceptor is different. Every interaction, every facility is different. So give yourself some time to kind of get into the groove and get to know each other and their flow. And that's another big thing to take out of clinicals as well, is just getting the feel for a flow of how things go day to day. And watch the interactions between your preceptor and the patients, kind of pick up on the vibe that they have and try and mimic that as best as you can. Of course, you'll bring your own flair and strengths to that too. I mean, as a preceptor, I learn things from my students all the time. So have a great time and learn as much as you can while you're there. Let me jump into last week. Okay. So last week was pain management in labor, and you guys did a great job on your forum. I'm just waiting for a couple people yet to respond back and forth. It's Sunday afternoon, so you still have time to do that. So, but I'm almost done, and everyone did a great job. It's interesting to see how different people manage the same scenario. There's really not, I mean, in some cases there are wrong answers, but the majority of time there's not a wrong answer. It's just nice to see different people's perspectives. And then in this forum setting, it's really nice to see, well, if I was managing that patient, this is what I would have done, or vice versa, things like that. So even for myself, reading the case studies, like the patient who wanted to get in the tub, or that was an option at 3 centimeters, I believe it was. Our facility has a policy that it's 4 centimeters, just because it can potentially slow their labor down. However, I think there's a little room for interpretation of that. You know, if I'm confident the patient is laboring well, baby looks fine, and she's really uncomfortable, then I would maybe discuss that case with the patient, let her know that this could potentially slow your labor down, but it's, you know, if you'd really like to get in the tub, I think that's an appropriate choice. So that was mentioned in several of your case studies this week, that we have to be very individualized with our patients and the situation, the facility you're at, what options you have available, even as far as the pain medications that are available. For our facility, for sure, we don't have access to Stadol right now, and our pharmacist has told us that there's a nationwide shortage of that, and that was one of our go-to main medications. Working in a rural health setting, we have epidurals, water birth, Stadol, and nitrous. So now we have the use of fentanyl, which is new to me, but good job on your forum. And I appreciated the feedback going back and forth. Okay, so this week we're going to talk about normal second and third stage of labor. There are several readings to do here in Varney. You can all kinds of interesting things, the hand maneuvers, injections for laceration repair, management of the third stage of labor, inspection of the umbilical cord and placenta and membranes. So all kinds of things to read there. You can read Williams' Vaginal Delivery, chapter 27, if you'd like a little bit more insight onto that as well. There are some videos to watch. They're very short. Hand maneuvers, active management of the third stage, and normal vaginal birth just kind of shows you as an animation how the baby comes through the birth canal there. Second stage positioning and a PDF of that as well. Excuse me, I'm recovering from COVID, so I got a bit of a cough. One thing I thought of as I was reading those, looking at those videos earlier, is that I offer patients to see their placenta after it's done. I think it's pretty fascinating, and a lot of people never get to see a placenta in their lifetime. So as I'm inspecting it, you know, mine's usually on a little cart, kind of spread out with all my instruments. And so I ask if anybody who's present would like to see the placenta as I'm inspecting it. And more often than not, they say yes. And so I kind of just take my show on the road and push my cart over next to them. And I kind of show them what I'm looking for, kind of point out how interesting it is and how it worked so well to grow such a great baby. And then your body just said, I'm done with that now. I don't need it anymore. So it's kind of fascinating and interesting for patients to see too. Now, if they don't want to see it, that's fine too, but it's kind of nice to give them the option if they'd like to. In this week's activities, we have two things. One is the normal second and third stage collaborative case study, and then the second part is the sharing forum. So we can look at the collaborative case study, set up similarly to other case studies you've done in the past. Your case studies, your groups are assigned to the different case studies, 1, 2, or 3. And you'll go through with your group, making a slide that you can share, and then answering the slides that are presented there. See, I think I have one here. So here's one. I can't remember which one this was. Case study 1. So a 32-year-old G1 P0 at 40 weeks, 4 days gestation is being induced for post-dates. Her prenatal and medical history is without complication. She arrived at the hospital yesterday evening for Cervidil. Her Bishop's score at the time was 4. Cervidil was placed without difficulty, and when it was removed at 8 a.m. this morning, her cervix was 460 and -1. Pitocin was immediately started. Membranes ruptured spontaneously at 15:35. Fluid was clear. For pain relief, Nubain was given at 1845, is now 2000, and PIT is at 16 millunits. Her current cervical exam is 900 and +1. Fetal heart tones have been reassuring throughout and are now showing some early D cells. What could potentially be going on there? List the top 3 priorities of the management plan at this point with rationale. And then you just go through and answer all the questions, dividing up the questions amongst your group members. So whether you have too many group members, too many slides, figure out how you're going to run that. And make sure that you put in the slide notes which of you did each of the slides so everybody can get credit. Let's see. And then this just talks about the forum section. During the second half of the module, take time to view the collaborative slide decks provided by groups different from your own. Select 2 slides from another group and respond with were there any similarities or differences in the approaches to assessment or management, and offer words of encouragement as well as other ways to approach the clinical picture if applicable. So as you can see down here, so here's your case study section, and then here's where you'll do your collaborative case study sharing forum. So that is it for this week. A lot to think about. I'm sure in addition to doing clinical, lots of things to think about. Often when I saw the repair of genital tract lacerations and infiltration for repair, that's often one students aren't too terribly scared to jump in and do a delivery, but it often takes a little coaxing to get them to do a repair for the first time. But I think once you do it, just do an easy one. It's a little bit easier. So even if your preceptor wants to start the repair and get it almost done, just so you can get used to feeling those instruments in your hand in normal tissue, maybe you could just ask to finish it when they're close to being done. That would be a great way to jump in and not be so nervous. But everybody has different procedures for how they work with students and what they offer when and all that kind of thing. So don't be afraid to jump in. If they say, do you want to finish this repair? You're like, I sure do want to finish it, because they'll be sitting right there over your shoulder with gloves on, ready to jump in and help if you need it. So just bite the bullet and get in there and do it. So good luck with this week. Let us know if you have any questions. Enjoy every birth. One good tip I have for you from when I was in your shoes, my preceptor Jeannie, I had her the whole way through, and we kind of ran through birth every time afterwards, whether it was the next day at clinic or right away. But that way you're comfortable talking about, like, what did we do well? What went really well with that? And what could we have done better? And it's just kind of a nice way to non-judgmentally kind of break it down and hash it over. So consider doing that. If maybe your preceptor hasn't offered that, maybe it's a nice way that you could get some feedback every time. So let me know if you have any questions. Good luck. I know you'll do great. Take care.